All right. Good morning, Facebook, YouTube, Instagram, Mighty Networks, and welcome to another episode of Hanging with Dr. Cooper. I'm glad you are here, and I want to take this opportunity to welcome my guest. We have a lot to get to today. My guest is Dr. Walter Z. FALCONER, MD, top doc, urologist here in Atlanta, and we've got a lot to discuss this morning about men's sexual and prostate health. Good morning, Walter.
Good morning, Coop, and good morning, audience. So glad to share this morning with you and talk about some topics that are interesting to all of us, and glad to have this format to reach out to the community.
Yeah. I think the ladies need to understand, and probably more than the men do, how important these topics are. Walter, tell me a little bit about you. I know you're from Atlanta. Went to the house. Tell us a little bit about your upbringing and your education.
Yeah, that's my story. Grew up here in Atlanta, went to product of Atlanta public school system. Most people in my generation are, and went to Southwest High School. Ultimately went to Morehouse College. Enjoyed that experience. As you know, you had your young son is there now.
Yeah. Been a little different experience with COVID, but he still had a great time.
That's right. He's gonna have a great time.
Yeah.
But I was a pre-med major and matriculated, went off to medical school at the University of Pittsburgh.
Yeah.
And, did my medical school there and ultimately chose the field of urology and was able to come back to Atlanta. And I trained at Emory in the affiliated hospitals, and I did my general surgery and urology training there. And
cool.
And went into practice.
Man, how many years now? How many years now in practice?
This is my 28th year in practice following my residency. So.
Oh wow, man! I do want to just acknowledge one thing, and you may not recall this, but my very first rotation as a general surgery resident was at Crawford Long Hospital, now Emory Midtown Hospital, and I remember walking in the grand rounds, and there were these two brothers in there, and I felt so relieved. Because there were these two brothers sitting in the surgical grand rounds, and you were one of them. Emerson Harrison was there. I think Titus may have been there as well. And I saw all these African-American men. At that time, I think Joe Hoffman was still there practicing.
Yeah.
And there was another orthopedic surgeon there, Titus Duncan, Dennis Turner. And I just remember walking into that room as a young African-American. Now, I'm from a little small country town in Missouri. Went to college and medical school at the University of Missouri, Kansas City. There were only 7 African-Americans in my class. But walking into that room, literally, like my first week as a general surgery, everybody just think about this now, first week as a general surgery resident, and having seen a few African-American physicians, but that was the first time in my life I'd ever seen that many, and it was only about 5 or 6 of y'all in that room at the same time. And man, let me tell you something, man, you don't know, I go back to that moment often when I think about people I know, but that was so inspiring to me to look around that room. And there was one person in that room. One of them walked up to me and introduced himself, and that was one Walter Faulkner. Also, Daryl Tooks was there, as a matter of fact. And but Walter Faulkner came to me, "Hey man, how you doing? I'm Walter, I'm a urologist. Just want to meet you. You're resident, whatever." I said, "Yeah." And he said, "Man, you ever need anything? Just let me know." And I appreciate that. So I just want to say that for the world to hear it, because that's so important. For young African-American men to see other people that look like them, quite frankly, and know that they're going to be okay. I had mentors of all types. It didn't, my main mentor was Robert Guyton, who grew up in Mississippi. But I just want to say that in terms of, African-American men and seeing you guys there was really inspiring to me. So I just wanted to say that.
I remember that, Coop. I remember.
Yeah, you do that. Remember that? You remember that?
We're just kind of reaching out and say, "Hey man, are you okay?"
Yeah. Look, I had a little short jacket on. Looked like I could barely tie my shoes.
I'm pretty sure you paid it back too when you saw someone there just kind of walking in your shoes, nervous. You're just small fish in this big arena, and just someone just to say, "Hey, keep it going, man. I understand." And I remember that as well.
Yeah, man. So and I tell my son all the time in terms of. Going to school in Morehouse, and he understands that now. He didn't understand it going in, but he understands it now, the power of the brand and the fraternity and the bond and the fellowship. And I said, man, look here. And I told him, I said, one of the things and one of your biggest challenges is don't get so caught up in the world that you forget to do what other people are doing for you. And let me just tell you, we want to get back on topic because we got a lot to discuss here. But I had two more house men, just over this last couple of 3 months, independently, on their own, reach out to me and say, hey, man, I know your son is interested in real estate. Here's a couple of things going on this summer I think he may want to look into. Have him give me a call and I'll walk him through the process. I was just like, are you kidding me? This is the way it's supposed to work. And it worked out great. And he's going to be interning this summer with Cushman and Wakefield. And I'm so proud of him. But just because they say, hey, Coop's son is interested in real estate, they're looking at something comes across their desk and they send it over to him. Just for being a part of the magic of being a Morehouse man. So I understand that, and I respect it a lot. Walter, let me ask you a question. How'd you get interested in urology?
Well, it's interesting. When I went to medical school, I wanted to do plastic surgery. And I knew early on I wanted to do a surgical subspecialty, and had done all this research in plastic surgery. And I did one of those just rotations. We have to do in medical school, the electives in urology. And it was something about the patient population, not they're not plastic surgeons. I think they're fantastic. They do wonderful work. Again, this was 1984, and I said, what's going to be my contribution, and just kind of connected with the patient population. It still was a surgical subspecialty. And it just moved me. Something about those older men, the experiences you have with that, being able to help them, in a way. Such a great field, man. You can do medical things, you can do pediatrics, men, women, young, old. We have a procedure, you can do cystoscopy. You don't have to just be a surgeon. As you get older and we kind of pass the baton, you still can carve out a practice that's really not a surgical practice, but still very important to the community. So it moved me. It was just kind of drawn to this as a surgical subspecialty.
Yeah, that's real cool, man. Just interesting fact with Coop. When I was actually interested in urology when I actually did a 2-month rotation up at Boston City Hospital in urology, and I would echo everything you just said, which was it was amazing, man. Because if a man can't urinate, you can't pee. That's a problem. And let me tell you something: to see the faces when they actually can get that relief. Was incredible, but I just want a little bit more blood and guts and a little less pee. So, I
something's gonna leak on you.
No doubt about it. Well, Walter, one of our subjects today is one of the things we want to get to. We got a lot to talk to, man. I may have to have you come back because I'll tell you when I started getting into this urology thing, this men's health issue, there's just so much. And there's so much noise out there. So we want to try to synthesize some of the noise and get to the facts. So the first thing we want to talk about is prostate cancer. Just give us a little bit of some of the high level facts and figures related to prostate cancer.
Yeah, here's the prostate cancer is the #1 cancer among American men. It's kind of second behind skin cancers in general, but it's the #1 cancer. And of interest, the highest incidence of prostate cancer in the world with African American men. Well, the second highest are with Caucasian males in America. So this is a real disease in the American community. It affects African American community. It's much more prevalent. But the prostate gland is one of our reproductive glands. It produces the semen when we ejaculate and mixes with sperm. That's the function of the prostate gland. So it's not a vital organ. It's important for our reproductive health, our sexual health. And a couple of conditions that happen with the prostate as we age. One is that it naturally enlarges. It's a sign of long life. Our prostate gets bigger, but also can form cancer. And that's the challenge we have because those distinct changes that happen as we grow older can mimic one another. And so it's very important to screen patients. Of course, if a man has prostate cancer, make the diagnosis early as opposed to the later stages in that patient population.
Good. Walter, the prostate being one of those glands and organs in our body that is sort of hidden. You can't see it, feel it, touch it. It doesn't have that physical sort of manifestation. Tell me a little bit about how do you go about, first of all, assessing your risk for a prostate related issue and sort of noticing perhaps some symptoms that could be a sign of a prostate issue?
Well, the risk increases with age. That's one thing we know for all men. As we get older, the incidence of prostate cancer rises. But also the other risk factors are family history of prostate cancer, and men of African descent is also a risk factor. One of the challenges are in the early stages, the man has no symptoms. So if the man depends on these voiding changes like difficulty urinating, hesitancy, waking up at night, those can be a sign of enlarged prostate, but they can be a sign of advanced prostate cancer. And so our recommendations in the man we recommend screening at age 40. And that screening entails a blood test called a PSA, which typically is done by your primary care physician. You don't have to see the urologist, coupled with a digital rectal examination. That's been our challenge. But men don't like that finger work. That's the one that it hits my turn. I'm like, oh goodness. But it's just part of it. That's the recommendation, because there are some cancers that don't make PSA. And so we can't be totally dependent on PSA. Patients say, well, can you just do the blood? Yes, we can, but it's a suboptimal screening test. So the recommendation is on screening is a PSA and a digital rectal examination once a year, starting at age 40. And that's our recommendation.
Yeah. And so, I have a problem because my primary care doctor, Dr. Mark Harrigan, is a friend. So he takes out all his frustration on me every year when we have I have to have my DRE, my digital rectal exam. I say, brother, let me tell you something. I'm gonna get you back one day if you ever need your chest cracked. But anyway, so the symptoms are really, what you're saying is really the symptoms are very, very, it kind of be very indolent, kind of, subtle. And so it's important at age 40. Then that DRE, should we have a PSA every year after the age of 40?
Yeah, absolutely. That's the recommendation. Mm-hmm.
Got it.
We have in high risk groups, like if I have a male who has a family history of prostate cancer of African descent, sometimes we'll screen them twice a year, with a PSA. Okay. Recommendations are once a year.
Got it. So I have, there's been a little controversy about the PSA. And I think that confuses a lot of people. And just give me your thoughts on, a little bit deeper on that, because I think sometimes in the absence of a really solid message and a very credible messenger, then all kinds of crazy stuff fills that void. So just give us a little bit more perspective on some of that controversy around the PSA.
Yeah, well, there have been mixed messages. What PSA is, it's an enzyme that's produced by the prostate gland. One of the problems as a screening test is that it's not specific for prostate cancer. And so there are a host of people historically along the way says, well, PSA doesn't mean you have cancer. No, it doesn't. It's just a screening test. The majority of men who have elevation of the PSA don't have prostate cancer. They have enlarged prostate. The recommendation or the what's normal is a PSA from 0 to 4. That's the patent on the PSA testing. So if the PSA is above 4, then obviously the patient should have some testing. But we also now look at age-specific numbers, like what's normal for a man, 40, 50, 60, and 70. So a man can be 41 years old and have a PSA of 3.5. Well, it's under 4, but yet it's too high for his young age. And so those are the things that we start to look at as urologists. Unfortunately, in terms of the cutoff, there was a group called the U.S. Preventative Task Force that put recommendations out about 5 years ago that said that men, once they hit the age of 40, didn't need prostate screening anymore. And the American Urological Association was different. We thought there were poor recommendations because, as you know, number one, we're living longer. Okay, so sometimes a life expectancy of 10 years or greater, you absolutely need to evaluate their PSA. I mean, there's some men who are 75 or diagnosed with prostate cancer. You can't make the assumption that it's always a slow-growing tumor. So we're still evaluating those patients. We still think that you do it on a case-for-case basis. You shouldn't be a hard line on PSA screening, but there are mixed messages. And it gets out that some people say, well, I don't need a PSA. I'm too old to have a PSA. They say it's not a good test, but right now the screening of and use of PSA is the one thing that's increased the early diagnosis and detection and cure of prostate cancer in all these men. You ask any man who's been cured of prostate cancer, how did that happen? I went in, had a PSA and DRE done. They diagnosed prostate cancer in the early stages. I am cured from it because of the early diagnosis.
Got it. Understood. Then, Walter, let me ask you. So the digital rectal exam is suggestive, meaning you feel a lump, a bump, or enlarged prostate. What tests then you do go through to either confirm or refute a potential diagnosis of prostate cancer?
Yeah. So if you have an elevation or we feel something on the digital rectal examination, the next test is to make the clinical diagnosis is a biopsy of the prostate gland. Well, that's coupled now with an ultrasound of the prostate gland. So ultrasound is just the technology we use when women are pregnant to image the prostate. We're looking now within the prostate gland, and so we're prepared to do a biopsy at the time of that. So the ultrasound serves as a guide to the biopsy of those suspicious lesions. We do have the introduction now of prostate MRI, which has really helped. It obviously the imaging techniques are much better with MRI. So now we're incorporating these MRI fusion biopsies, for patients. So we've gotten much, much, much better. When I was a resident, man, we used to do blind biopsies, Coop. I mean, we had no ultrasound guide. We just kind of, old true cut needle, this back there, hoping you would get the cancer, feel something. So our diagnostic and techniques are so much better now. So people think there's so much more prostate cancer. It's really not. We just have done a better job in picking it up and diagnosing the screening tests and diagnostic capabilities. So.
Got it. Understood. So diagnosis is confirmed. Then what are the next steps in terms of decision making from a surgical perspective?
Yeah, a lot of it depends on what's kind of risk profile. If it's a younger person versus an older person, and there are certain things, pathological features that we find on the biopsy, something we call the Gleason score, which is how really aggressive the cancer type is. Is it a slow growing tumor, or is it one that we suspect is going to be a very, very aggressive growing tumor? Prostate cancers in general, when you compare them to other cancers, are really pretty slow growing tumors in general. But the decision making then comes in what are our choices for treatment. Historically, the gold standard was surgery. So over 100 years, we've been removing a man's prostate gland who has prostate cancer. That has evolved now from an open operation with a big incision to something we call a robotic prostatectomy. It's really removing the prostate with a scope and having the advantages of that technology to remove the prostate. So that is the standard of care now for the surgical removal. About 30 years ago, we started doing work with radiation. So there are radiation treatments for the prostate, either external radiation or the placement of radiation pellets or seeds in the prostate. Been a very successful way of treating men with prostate cancer. We have an application of cryotherapy, which is freezing the prostate. Actually make it ice, and when it thaws, it destroys all the cancer within the prostate gland. There's a newer treatment, this high frequency focused ultrasound treatment that you do in Europe. That's another application. And then there's some men who choose to do nothing. We call active surveillance. You say watchful waiting. These are men who you suspect that the prostate cancer is growing very slow, or they have a lower Gleason score. They may choose to just follow the cancer along over the years with some screening and PSA and biopsies periodically. And some patients have that choice, and they choose that option as well.
Yeah, so the real difficult, I think, decision making process for men with prostate cancer is trying to figure out, or trying to choose. D Banks, our good friend D Banks, chiming in, the idea of preserving sexual function versus aggressive treatment, because the prostate is intimately intertwined with our ability to engage in sexual function or have a healthy sexual function. Talk a little bit about that, Walter, and the various treatments and their effect on that.
Yeah, it's a huge challenge for us. And the prostate, the nerves that supply the male erection run close to the prostate gland. They don't run through the prostate gland. But if you look at the side effects of the treatment of prostate cancer, erectile dysfunction or loss of erection has been one of the things that's been the biggest challenge. We try now surgically to do what we call nerve sparing techniques and push the nerves aside and try our best, but the goal is to remove the cancer. But it has been a barrier. One of the better things that's happened now is that we have all these treatments for erectile dysfunction. So 34 years ago, these unfortunate men, that was just a consequence of the treatment. And that permeates in the decision making for someone who says, well, if I'm not going to do anything, then why should I even be treated? But it's a challenge. I mean, it's one of the things that patients are most concerned about. We do see variations in the different treatments on which has a higher incidence of erectile dysfunction versus not. But again, the goal, I tell patients when I do talk, last time I checked, no one's having sex in the cemetery. Okay.
Ooh, boy, that's a hell of a choice, Walter. Oh my God, that's a hell of a choice. Yeah. When you think about then, let's switch over now a little bit. Well, before we do that, tell me a little bit about some of the adjunct treatments for the prostate cancer: radiation, chemotherapy, hormonal therapy. When does that come into play in the treatment of prostate cancer?
Yeah, well, for those unfortunate men who have advanced disease, say we didn't get it in time when it's in the early stage 1, or the unfortunate cancer progresses. We've known for almost 60 years that prostate cancers respond to the absence of testosterone. So if I can lower a man's testosterone level, the cancer will go into remission. And we've treated that for many years. Historically, it was, believe it or not, castration or removal of the male testicles. Now we have medications. There's a shot that can do that, or some oral medications that can treat that. There is a role for chemotherapy, but it's not the first line treatment. Is when these other things have failed. What's really been interesting for us, Coop, is in the past 10 years, it's just been this bombardment of these new medications for prostate cancer. Back in the early 90s, there was a lot of US dollars spent on prostate cancer research, and we pushed for that. And we're now seeing the fruits of that with all these new drugs that are coming out for men who have advanced prostate cancers, new treatments from immunotreatments, which are designed to create antibodies, for the patient that attack prostate cancer cells, to now some genetic testing that have better treatments for patients who have gene mutations. It just really is exciting, particularly for those men who have advanced disease. That was our barrier. We had diagnosis. How do you screen it? How do you diagnose it? How do you treat it? But then for those unfortunate men who had advanced disease, what were the things that we could provide for those patients? So it really is a good space where we are now for these wonderful treatments that we have available. We just have to know a man has prostate cancer, and knowing about it, we have a lot of things that we can do to cure them, prolong their life. I mean, significant changes in life expectancy, even for men who have advanced disease. The other thing I want to talk about is also prevention. Okay, so now we're at high risk group. Say you or me, we're of African descent. We're in a high risk group to me. There's new data that talks about there are some foods that we find, or certain kind of diets that are important to lower prostate cancer risk. I tell patients a heart healthy diet is a prostate healthy diet. We know that low fat, low cholesterol diets benefit and lower the risk of prostate cancer. But there are also some herbal formulations that we consider, things like lycopene that are in tomatoes, and vitamin D, vitamin E, selenium, zinc. These things that I tell patients, these prostate wellness formulas really are showing to lower risk. And that's really where we should be. What am I going to do on a daily basis to lower my risk of prostate cancer? In general, I'm at high risk just being an American male. Here, the number one cancer. So we need to get in front of this, as opposed to I hope you never come see me. That's
that's a very good segue into the issue of just health in general. And a few years ago, I had a good friend, who asked me on the side, hey man, I'm trying all these pills, I can't get it up. I said, well, look here, brother, let me break it down for you. I said, you're about 50 pounds overweight, you smoke, you don't exercise, you eat just about everything somebody puts in front of you. I'm just going, come on, my man, let's do the things we can do first, and then we can start talking about whether or not you need to be on Cialis or need to be getting your prostate or dealing with your erectile dysfunction. And that's exactly true. And so, one of the questions in the chat from your Morehouse brother Ken Sappho was, which is an issue that a lot of men, as we get older, this is a real dynamic situation getting older as an African American male, because low testosterone and testosterone replacement and the risk of prostate cancer. Talk a little bit about that in guys who suffer from low T and just sort of this fatigue and exhaustion And then how do you combat that safely?
Yeah. Well, testosterone is the male hormone. Women have estrogen, we have testosterone.
Right.
And historically, we didn't really put a lot of value in testosterone. It was just kind of some, your level was normal, and that really what was the implications of having a lowering of testosterone. There is a natural descent of our testosterone. Our level probably drops about 1 to 2% per year once we get over the age of 30 or to 40. The highest levels of testosterone when we go through puberty, when we're teenagers and in our 20s. But it's a natural descent. But there are some patients who have kind of a rapid descent, and then they'll have a truly low value. And if you couple that with symptoms of low testosterone, which could be decreased libido, sexual drive, but sexual performance, but not just in the bedroom, things outside the bedroom, like energy levels, muscle mass, this obesity of the stomach, those kind of changes coupled with a low testosterone may warrant us to add testosterone, a supplement testosterone for those patients to have a better well-being in general. And so there are patients who have low testosterone, they're diagnosed with that. And typically your primary care doctor will check that now as a routine. You can supplement testosterone, and it's not juicing. It's not the anabolic steroids that it's testosterone that we give, and a couple of applications either through a gel or a patch or a shot or injection, or we have a pill or nasal formulation. A lot of delivery systems, pellets. What you have to be careful with, it's interesting because testosterone does not increase the risk of prostate cancer. Okay, what it does, it increases the likelihood of the prostate gland to grow. Okay, in law. But if a man has prostate cancer, or undiagnosed prostate cancer, it can make that progress. And so you have to make sure before you begin to give patients testosterone that they don't have prostate cancer. But it doesn't really increase the risk. And that's the statement from the American Urological Society Association.
All right. Oh, good. Thank you for that answer. So that clarifies it does not increase the risk. It can increase enlargement or hyperplasia of the prostate. But it's important to know if you make sure you don't have prostate cancer before you start supplementing, because it will actually feed the cancer and allow it to grow. And so now, one of the things in the big billions and billions of dollar market out there is men's sexual health and erectile dysfunction. We talked about, clearly, let's start with the simple things. I mean, you and I have the same conversation in our offices. Eat right, exercise, live a healthy lifestyle. All that, it applies to every organ system in your body. Yeah. So we're doing that, but now we've got the issue of addressing erectile dysfunction in men. So we've cleared up. They don't have prostate cancer. They're trying to do the right things. What is your approach to that issue? Very big issue, and a lot of things out there. You and I have had conversations about some of these things. What's your approach to that? That's obviously one of your areas of expertise.
Yeah. I do think, as you say, a couple, behavioral changes as part of this, getting better. There are men, there's a higher incidence of erectile dysfunction or ED in diabetic males. It's patients who have hypertension, or sometimes the treatment, antihypertensives can affect the man's erection and things. So my approach is to kind of do a good physical examination to understand what medications they're on. Okay. And my first line is to use these PD5 inhibitors, this class of medicine like Viagra and Cialis and Levitra that have been wonderful attributes for men. What's good about them that they're typically used on demand, so the men take it when they're going to have relations. There is a formulation of Cialis that's a daily dose, but the majority of men will use these medications on demand. Now, there are certain risk factors that or contraindications, say cardiac arrest surgery. These men who take nitrates, or nitroglycerin, nitrogen-based pills, they cannot and should not take these medicines with that. It's very, very important. I have some patients too. I tell them they're hypertensive medication. They say, "Well, doc, when I'm going to have relations, I stop taking my antihypertensives." Just trying to figure it out, and that's not smart as well to the viewership. So it's important to see someone who can direct that. Now, if there's a failure of that, there are tests that we do. There's actually the use of, we call it Doppler ultrasound, to really now give us a picture of anatomically what's going on at the level of the penis. Are the blood vessels open? Are the veins collapsing to hold the blood in. So there are tests that we do as urologists to evaluate the question, why am I having erectile dysfunction? Not that I'm having, but why am I having erectile dysfunction? And therefore, we can assign the better treatment. There are hosts of other treatments, like these injections or shots that we give men into the penis, and applications of that. There's a vacuum erection, the pump that the man puts over the penis. And then there's some surgical strategies that we use as urologists to put in a penile implant or a pump for those men who fail all the other treatments. So there's a host of treatments, but the evaluation is key. And you're absolutely right. The general health, tell patients, our goal shouldn't be to give you Viagra. Our goal should have you have your natural erection back. So you begin working out, do aerobic exercise, you can change a lot of that yourself without going to the next levels of the treatment.
Got it. So you know, and again, the take home message are many, but the big one is the take home message is, you know, we need to focus on the things that we can do, which we can change our habits. We can change our lifestyle, our approach to our lifestyle, our eating, smoking, drinking, and all the other bad habits that we have. And we can start with those things as it relates to erectile dysfunction. So the medications bring along, Walter, some side effects, and oftentimes, you know, we talked about not taking them if you are a heart patient or for some other reason you're on a nitrate or some other types of classes of medications. You do not want to be taking Cialis and Viagra, certainly without, you know, making sure that you cover that with your doctor and that it's in a very controlled and environment and somebody's monitoring it. But in general, don't do that. But so we're having side effects. We just can't tolerate them, or they don't work, which we know in about a third of patients, they just not going to have any effect. What would be some good alternatives to the medications in terms of, or what would be the next thing that you would maybe consider for a man who's unresponsive to the PD5s?
Yeah. Well, the next kind of classic recommendation that's really approved by the American Urological Association is the use of these injectables. These are patients who will inject a prostaglandin into the penis. We teach the men how to do that themselves. You know, at the time they're going to have relations, they'll inject themselves about 10 to 15 minutes, and it will give the man an erection. You know, and we kind of titrate the medicine. You want something that works, but also doesn't last too long. You remember that commercial, erection 4 hours. You know, having a prolonged erection isn't a great thing either, because it's the trapping of blood in the penis. So, so try to figure out what's the sweet spot for those patients. That's kind of the next line of treatment. There are some kind of newer treatments that aren't really approved yet. If you look at our recommendation as urologists, because there's not a lot of evidence-based medicine, but they're out there. This use of kind of these protein-rich, the platelet-rich
plasma, yeah,
and where they inject into the penis, and the stem cells. All these things are done just all off label and not a lot of science to it. There's maybe some anecdotal improvement, you know, from patients, but our recommendation is that there's no evidence base to show that works in patients. There's a newer treatment called GAIN. It's a shockwave treatment to the penis that they've done in Europe for many, many years. We brought that application to the US. It works in selected patients, probably in the patients who have mild ED, patients who have severe, it really doesn't seem to improve that. But one of the challenges too is that we see as urologists is that there's a lot of direct to consumer advertising, the sports page, the radio ads about these men's health clinic and these shot clinics. Yeah, we don't mind. We it's not the competition. It's that my problem is that they don't take the patient's insurance. So a lot of patients go pay a lot of money for this kind of cash thing, but the insurance covers it anyway. And they're not the experts. You know, they you know, in the state of Georgia, you have a license to practice medicine and surgery. Okay, I can practice cardiothoracic surgery if I wanted to.
That's true.
That's what Georgia says. You know, I can be a plastic surgeon. Now the hospital may not credential me to do it. You know, plastic surgery clinic on the side, and we can do that. So you have these facilities, and it's okay as long as they're taking care of the patient, providing care, but they're also sometimes driving revenue because they're selling the drug and things. And so I think patients, don't be leery of them, but you want to make sure that you're dealing with people that have your personal self and your wallet or pocketbook in their better interest as well, too. Medicine is a business, but it's not a cash. We shouldn't do things based on revenue. It's just taking care of people, being righteous, and you'll be rewarded abundantly. That's how it works, to me.
Yeah. So Walter, let me ask you that. So who would be an ideal? Man, we got so much to talk about here. I'm gonna have you come back because we haven't even gotten to many questions yet because we got a few in the chat, and I do like to address. And I just want to just pause for the calls. You're hanging with Dr. Cooper. I appreciate all of you all being out there. Art, you've been on here. Art Rains, our buddy, says hello there, Walt. And we got I see Carmen. Yeah, Nancy, how you doing? Nancy Brown. D Banks, Tabitha, Miss Greer, how you doing? Coming in from St. Louis. Appreciate you. Ken, you were here early. Sappho, T Page, you're one of your patients, he says. Walt and Chad Lee, PBG on the stream, and making comments, and perhaps even others out there. I really appreciate you all. Remember, like, subscribe, enable notifications, and share, please. Like, subscribe, enable notifications, and share this information. This is all for the benefit of the people who take the time to actually get this information. And we're here because we want to talk to you. We want you to hear from us rather than the direct consumer market out there that's pushing pills and various off-label treatments. Walter, who would be a good candidate for implant therapy? Where would that apply?
Yeah, I mean, the evolution of implant has been wonderful. I do a lot of implants in my practice, and it's the patient who's typically failed all the other treatments. It's not the first line treatment, never should be. We always should do this in a sequential fashion, medication, shots, and things. But there's some patients who just don't respond to those medications. A lot of these men will have, again, this is a vascular phenomenon. So we have vascular spaces and blood vessels in our penile shaft. Well, sometimes through scarification, a lot of diabetics who over time just don't have the chambers in the penis to fill with blood. So all the other things that we offer them aren't going to work. So that's a patient who the next step would be the insertion of a penile implant. They're typically inflatable. Historically, they were just rods. Now they really mimic what we do. They have cylinders in the penis, a pump that's located in the scrotum, and all this is under the skin, and a reservoir that holds the fluid that's filled with saline. And when a man wants to have a relation, he pumps it up and he has a rigid erection that he can use, stays up as long as he would like, and then he hits a deflate button to release that. And it really has helped out a lot of men because prior to this, just hit a roadblock. They could not have an erection at all. So the pill and the other shots, those treatment they have the highest percentage use. But for those patients who just don't want to take these medicines anymore, that is an option for them. It is a surgical procedure. It does require some recovery and healing, and some surgical, potential side effects, but it is, done well. I always counsel patients, we have in our group several of our urologists who are kind of champions. We do these procedures, and that's the thing. You want someone who really does this as part of their practice, versus someone who just does a few of them a year. Someone who does, over 60 or 70 of these a year is what you're looking for in terms of volume.
Got it. Walter, there's some questions. D Banks asked a question about nerve sparing surgery for prostatectomy and the success rate of that. But I think I want to preface that statement and comment in your response with it sounds like what you're saying, however, for the men who have the prostatectomy that end up, back to that conversation, that end up having erectile dysfunction after the prostatectomy, but there's still hope for you. There's still some obvious things that can be done to get you so that you can have healthy sexual relations and have a healthy erection. And that sounds like to me what you're saying, but I'll let you comment on that, the nerve sparing, and then now the post-prostatectomy issues that men are so afraid of.
Yeah, we've evolved as urologists. When I was a resident, we used to tell men, well, wait a year and then we'll kind of deal with your erection. That was wrong. What we now identifying these patients are going to have surgery, but should we be having them do things that oxygenate their penis ahead of time, like use a vacuum pump? We'd be prepared for this. The nerve sparing techniques that Dr. Banks is talking about, the nerves that supply the male erection run close to the prostate. And historically, when we did the old operation, those nerves look like hairs. Well, robotically, they look like guitar strings. And so you push those nerves aside. They aren't part of the prostate gland. They, unfortunately, in the old radical prostatectomy we used to do, we just cut through the nerves. So we thought that was all part of that. We just evolved, and so you push the nerves aside. And as long as you spare them on one side, you can have some semblance of erectile function. But unfortunately, what you're there is to cure cancer. So if there's any question of the nerves being involved, they have to be sacrificed. After the prostatectomy, we're starting now to, even not waiting a year, beginning some of these PD-5 inhibitors, putting the man on Viagra or Cialis on a daily basis. Because we think that some of the failures that occurred was that the man, just for non-use, you've had this surgery, you're kind of off the grid a little bit, and you're not using it. And so oxygenating the penis, getting blood flow down to the penis, we think helps those patients, or using the vacuum device. So we're starting earlier on to address that issue than we did when I was a resident, where we just said, hey, you wait a year, then we'll start looking at it. Well, at that point, they really don't have any function at all. So we really turn the corner. But the nerve sparing techniques is really the standard. That should be the effort for any surgeon to spare the nerves for that patient. But the patient have to go into this with the expectation that one of the potential side effects of the treatment is that they can have erectile dysfunction. That's the discussion that patients should have. In terms of the incidence of it, it's probably about 30% overall. It also depends on how young the patient is. If the man has a vibrant erection prior to it, he'd be able to maintain it. There's some patients who are on Viagra before their surgery. Well, it's not going to make them any better. They're probably going to be using that afterwards. So.
Got it. Understood. So, so the bottom line there is that there's a lot of treatments, gentlemen, for this. But again, as I always tell my patients, treatment starts with you. It starts with you deciding that you want. I mean, that's everything that we do. Period. As physicians, treatment starts with you. It starts with lifestyle choices. It starts with making those changes, attacking those things, and doing the things you can do. And then regular follow-up with your doctors, incredible people like Dr. FALCONER. So you all are hanging with Dr. Cooper. My guest is Dr. Walter FALCONER, who's urologist with Georgia Urology, and is discussing men's sexual health and prostate related issues. Walter, let's talk a little bit about one of the cosmetic issues, and also one of the issues with men with erectile dysfunction is Peyronie's disease and the curvature in the penis. And now there's even treatments now that, talk about treatments and the evolution of therapies and for various conditions. It's amazing to be a practitioner in this time, because, these things are really amazing. You mentioned the treatments for cancer. I read something a few years ago, actually not a few years ago, within the last couple of years, are going to be, well, we already passed it. By 2020, over 21 or 22 million people living with cancer. And I'm not talking about suffering from cancer. I'm talking about living with it because of the monoclonal antibodies, genetic manipulations, the so-called biologics, and even some of these protease type inhibitors and activators. It's really amazing. And one of those, it sounds like, is now evolving for treatment for, and so people don't know, Peyronie's is a curvature in the penis, which can be a cause of erectile dysfunction. And now the treatment for that, even surgical, sounds like it's a possibility now. So talk a little bit about the curvature in the penis. A lot of men won't talk about that, and they're embarrassed by it. It's cosmetically unappealing, and can be a cause for a problem. And there's now treatments for that. So talk a little bit about Peyronie's, Walter.
Yeah, Peyronie's, if you look at it, the incidence is just completely underreported. I mean, there are a lot of men, unfortunately, just silently dealing with some of these issues. But what it is, and it's not a disease. There was a Dr. Peyronie many years ago. Stuff you can get from someone.
Yeah.
That's just, it's Peyronie's disease, what we call it. It
Yeah.
really comes from a scarring of the parts of the penis that stretch when we get erection. And if I think our penis is elastic tissue. I mean, we grow. We grow in girth and length. But if you have an area that has scar in it that's not going to stretch, then you get this curvature of the part that doesn't stretch. And it can be so pronounced that the men actually cannot, it's so curved that they cannot penetrate things or have some erectile dysfunction as a consequence to it. And so historically, there was a surgical application. We would go in, and you can do surgeries where you put sutures on the other side and straighten it out, or you can cut the scar out and replace it with some other material. in the patients, or do we have this newer application with all these biologics where you inject medicine into the plaque, and what you're trying to do is just soften the plaque, and through stretching exercise, get the man back oriented in a straight direction. So it's really been only FDA approved medicine for that, which it's been a challenging condition to kind of find this. And there are men who we all have a little bit of curve one way or the other, but we're talking about significant changes. How it happens is actually through typically intercourse, where the man gets a little bend of the penis and he gets a little micro tear in the penis, and that's when it scars. Now, we do still treat several times a year who fractured penis. That's a real thing. The man actually it has so much weight that it blows a opening into the vascular parts, and that's a surgical emergency. You have to go in and close that hole, but that's a real condition that occurs. We may do, personally, maybe 9 or 10 fractured penises a year. Just being a little too aggressive, with intercourse, and so it's a real condition. Be careful.
Wow. Amazing. So question in the chat about urethral blockages from external. It sounds like cancer blocking the ureters, and being able to relieve that with stents or nephrostomy. That's an option. So I think Carmen Watkins asked that question in the chat. Any thoughts on that, Walter?
Yeah, Carmen. There are some patients who have progressive or advanced prostate cancer that the lymph nodes can block the urine. The ureters are these tubes. We have 2 kidneys, and the tubes bring urine down to the bladder. So there are a host of things that can obstruct that. The more common thing we have are kidney stones. People passing the kidney stone, the stone gets stuck in the ureter, and then we can remove the stone or treat the stone. Well, you can have that same kind of scarification or compression of the ureter through cancer and things of this nature. And so how we manage it, hopefully that we can put what's called a stent. Y'all know stents in cardiothoracic surgery. It's the same kind of philosophy, getting something out that allows the urine to drain from the kidney down to the bladder and facilitate the drainage. Sometimes you can't do that, and we put what's called a nephrostomy tube. Now it's a tube that goes into the back, to the kidney from the outside to drain that area. So, that obstruction of the ureter is more commonly seen in kidney stone. That's the more common presentation of that, but we can see it in other conditions as Carmen described.
Mm-hmm. Good. All right. So one of the things that that oftentimes the guys go back and forth about, as I always say that I accept everything that God gave me openly, willingly, and with great humility and thanksgiving. But there are guys out there who really suffer from who feel like they don't have enough girth in their penis, and penile enlargement or elongation. Is that a viable? Are there viable treatments for that, or should we avoid all of this hobjob stuff that we hear? Again, direct to consumer kind of stuff. So, comment on that a little bit.
Yeah. I won't say it should be avoided. I think, it was a big push for it back many years ago. These men who had these penile lengthening procedures. In the girth procedure, what they were actually doing was doing fat transfer. They would take fat from other parts of the body and put it around the penis underneath the skin that would increase girth. Well, that didn't have a great application. The penile lengthening procedure, there are some ligaments that we have that support the penis that you can take them down, and it makes the penis kind of descend. But those kind of treatments aren't FDA approved. They aren't sanctioned by the American Urological Association. There are some doctors who do them. I tell patients, find those doctors, because it's not a standard treatment. It's not taught in residency programs. There are maybe someone who champions that. I tell patients, I don't know. I don't know the outcomes. But there are doctors who do that as part of their practice, and I would encourage someone who they're interested in that to find those doctors, because a regular urologist is probably not going to be able to do that or do it successfully too. Again, it's about outcomes. It's the number that you do, and so those doctors may have a better outcome. But it's not something that we recommend. For patients. Just be happy with what you have.
As I say, God gave it to me, so it's mine. I accept it. I certainly am not going to give it back. Anyway, so in the remaining about 5 or 10 minutes we have, Walter, bladder cancer. Talk a little bit about bladder cancer, some of the things that we should be concerned about with the bladder in men and also in women. Everybody has a bladder, so yeah.
Yeah, we see a large number of women and men who have bladder cancer. Bladder cancer isn't high on the list of cancers in the prevalence, like, skin, breast, colon, prostate, lung, but it's on the list. And we do see a high incidence of bladder cancer. They typically presents with blood in the urine. So I counsel people, if you're urinating and see gross blood in the urine, or see blood when you wipe, or that's an indicator that something's going on. May not necessarily be bladder cancer. More commonly, it's a urinary tract infection or kidney stone, other things. But it's something that we evaluate patients, because there's still a high incidence of bladder cancer, which is really a tumor or cancer that develops of the bladder wall. Again, it doesn't have any external expression. It depends on blood in the urine. So you go in, your doctor will do a urinalysis. We look for things for that. And sometimes you get sent to a urologist. What we do is a scan, or have to do a cystoscopy, where we look into the bladder with a scope to make sure that the lining of the bladder is normal. Now, if a person is diagnosed with bladder cancer, the hope is that you can treat it through the scope. You resect it, you remove it. And if it hasn't invaded the muscle of the bladder, got it early enough, then that's the treatment of it with some follow-up. If it is in the muscle, then just resecting or removing it through a scope isn't enough. And then we start to get into the realm of cystectomies, or removal of the bladder, for life purposes, or radiation treatments for the bladder. Or we actually, believe it or not, have some of these newer kind of genetic models, these medications now that are working for bladder cancers as well. So it's not as prevalent. The highest incidence of bladder cancer comes with smokers. So we know it's something that is related to smoking. So as we've reduced that, incidence of cigarettes, we've seen the reduction of bladder cancers. I'll tell patients, I had a 21-year-old patient who had bladder cancer, and she vaped. That's the only thing she did, and she, of course, has stopped now. But I tell patients it really is directly linked to smoking or exposure to a lot of chemicals. So people working dyes around paints have a little higher incidence of bladder cancer as well.
Wow. And, it's amazing how all of this stuff seems to come back to the basic kind of stuff. Walter, I really want to I appreciate you for being here today. We're going to wrap up. How do we get a hold of you? If anybody out there has a question, comment, or wants to see you to deal with some of these issues, how would we go about doing that?
Yeah, cool. I'm in Georgia Urology. I merged my practice back 15, 20 years ago with Georgia Urology, which is the largest urologic group in the Southeast. We have 51 urologists peppered all over the city. And our website is www.gaurology.com. And my phone number is 404-292-3727. And I'm just, I love medicine. I like people. I like talking to them. I talk too much. I spend too much time on patients, and everybody gets mad. But this is my nature. And we just, as cool, we want people to be better,
Yeah, that's
right.
right.
To be around those old cats, talking about the old days, and we want those old days a long time ago. So if you have things going on with yourself, you not necessarily have to see a urologist. I tell the men, but definitely with your primary care doctor, you're getting a lot of the screening. So ask for a PSA and make sure you're getting a testosterone levels as part of your routine screening, and accept the DRE, men, it's just, don't kind of get away from that. And make sure your urine's being checked. And as Scoop says, think about it's what you do on a daily basis, what you eat and how you exercise that helps us help you. Is that help me help you?
No doubt about it. Well, Walter, I really thank you. And I want to thank everybody out there and that's been hanging with Dr. Cooper this morning. This has been a fantastic discussion. You all remember, live life, live it well, live it now. Today is the best day of your life. Tomorrow is gone. Yesterday is gone and tomorrow's not promised. So thank you once again for hanging with Dr. Cooper. We'll see you tomorrow. I have another show tomorrow with Dr. Trey Pickens Patterson III. We're going to talk about chronic pain management. We'll be right back here tomorrow morning, 9 a.m. Eastern Daylight Time. Thank you so much, Walter. On the other side, my brother. Thank you.
Be good.
Take care, everybody.